لا لمين؟ لا انا بدي اقعد هون.
بكره عندي لاب المايكرو لاب بس اخذت الاحد. لا كلهم تو فورس، كل اسئله تو فورس اللي اجت الثانيه. لا مش الثانيه.
درستي من الماده الانيميا؟ الانيميا درستي لا لسه. اذا درستي خلاص بتجاوبي لك بس صح سهل كان
يعني ما
سهل. لا ما نسيتكم غير انتم مين بس رامي. بس تعرفي اللاب الماضي جابت اغلب الاسئله من الكيس.
من جد؟ هذا شيء مش مختلفة بس عجبني هاي خجلتنا هاي المرة كل تو فورس يعني مستحيل تعمل بكيفي أصعب. عشان يمتحن ورقة كمان عشان بالغشوش. بس تعطي لها حنان نسيت الصبح بتاعها عشان الجايبة تيجي هذا بس تعطي لها حنان.
صباح الخير. طلاب الأونلاين can you hear me؟ سامعيني؟ Can you reply؟ طلاب الأونلاين
اتوقع في
Is my voice clear؟ طلاب الأونلاين Can you type, please? Thank you, Clara. So we started with acute leukemias. We already discussed ALL, AML. Today we will discuss APL, subtype of AML, acute promyelocytic leukemia. APL is a problem of differentiation of promyelocytes. They are not differentiating. So they are not growing into myeloids, and so they start to accumulate. The problem with APL, acute promyelocytic leukemia, is that it could be highly fatal if not diagnosed and treated. If diagnosed, the treatment response rate is really high. But if not diagnosed, it can cause coagulable disorder, hypercoagulability. This could be fatal. The problem of AML is lack of differentiation of myelocytes or myeloblasts. What's the difference between cell differentiation and proliferation? How these two are different? What's the difference between cell proliferation and differentiation? What is cell proliferation? Pardon?
Proliferation increase the number of cells. Differentiation هي إنه خاصة بتصير نوع معين من الخلايا.
Yes, very good. So if the cells are highly proliferated, how does it impact differentiation? Highly proliferating cells, are they expected to be highly differentiating? No. So the relationship between cell proliferation and differentiation is inverse, right? If we talk about cancer cells, do we expect these cells to be highly differentiating or highly proliferating? They are highly proliferating because we said that cancer is a disease of abnormal and controlled growth. So the cells are dividing at a very high rate. The proliferation rate is very high, but they are not differentiating. They are not performing a special function or task. Now here we have a problem of differentiation of myelocytes. They are not being able to become mature, to differentiate and do a functional myelocyte. And so a hallmark, a very important translocation here is T1517. There is translocation from chromosome 15, insertion into chromosome 17. Now the gene encoding here at chromosome 15 that is fused with chromosome 17 is retinoic acid receptor gene, RAR. It will move and diffuse at 17 chromosome next to PML gene. The result of this translocation and diffusion is that we lack ability of promyelocytes to differentiate. This is a hallmark of APL, very common. We find this very commonly in APL, and we can actually find the fusion chromosome here, okay, when we do FISH, fluorescence in situ hybridization analysis. We are tagging the chromosomes, okay, we are giving special dyes, fluorochromes to go tag the chromosomes, the transfusion chromosomes if exist. And so we can see if they exist in the nuclei or not, and we can also know the copy numbers available. So T1517 is a hallmark of the APL. Now, if we diagnose APL, then we have to start with induction regimens. The most important drug for treatment is tretinoin. What is tretinoin? Vitamin A derivative, right? Now, we give tretinoin here as a differentiating agent. It will help the promyelocytes to differentiate. So one group or class of anti-cancer drugs, we call them differentiating agents. If we induce cell differentiation, basically we make the cells less proliferating and we can help them to become function, okay? Now the other name of tretinoin is Atra, or trans-retinoic acid. It's the same name, it's the same drug. Tretinoin, Atra, the same drug. Now if we give tretinoin for induction, like about 90% of patients will actually achieve complete remission in 1 to 3 months of therapy. So there is a very high rate of complete remission. Now, how we give tretinoin and induction regimens? We have 3 options for induction regimens here. You can give tretinoin with chemotherapy, 2 classes of chemotherapy. So you can give tretinoin with anthracyclines, or with cytarabine, or chemotherapy-free regimen, tretinoin with arsenic trioxide. So these 3 regimens are potential induction regimens. If we want to give tretinoin with anthracyclines, we have 2 options, daunorubicin or idarubicin, one of these. With Ara-C, you can give Ara-C for 7 days. Or patients who cannot tolerate chemotherapy, we can give chemotherapy-free regimen, tretinoin with arsenic trioxide. Arsenic trioxide also induces differentiation and apoptosis. It can kill the immature, highly proliferating promyelocytes. So these are 3 potential induction regimens. Usually the choice of the induction regimen is also dependent on the risk stratification. A very important variable to look at when you treat patients that you can classify them into average risk, high risk is WBC count, okay, as a baseline WBC count. Now, if we give tretinoin with any of these, the activity of the regimen is better than using tretinoin alone. So if we talk about tretinoin arsenic trioxide regimen, this is synergistic. What does it mean, synergistic activity? When you say it's synergistic, it means what?
activity.
Not exactly. How is synergism different from additive activity? No.
الأكشن إنها مع بعض بيكون أكثر من الأكشن اللي كل واحد بيعمله.
Yes, good. So if tretinoin alone causes 20% response, arsenic oxide alone causes 20%, additive activity, you see 40% response for the combination, right? Synergistic, it's about the mathematical effect, the additive. فبالتالي إذا أنا بحكي synergistic activity, 20% give me effect of maybe 60-80%. That is synergism. And in cancer therapy, when we combine, the goal is not additive. The goal is to produce synergistic effect. Why? We look for synergism, not additive activity. Why?
The outcomes in resistance.
Because you get a much higher outcome at much lower doses. Okay? Now, if patients present with leukemia cells in the CNS, infiltration of acute promyelocytes, we have to treat the disease because we cannot use tretinoin. It does not cross blood-brain barrier. So we treat with the intrathecal therapy as we indicated for ALL. Now, after we achieve complete remission in induction, we move to consolidation. We have to treat all patients in consolidation. Now, the regimens in consolidation, tretinoin with an anthracycline or arsenic trioxide can be also used in consolidation, especially if tretinoin is not available. Maintenance phase, not considered for all patients. Not all patients need to go for long-term maintenance in APL. However, high-risk patients, according to the baseline WBC count, they must go for maintenance. Now, maintenance regimen, we have 3 drugs. We have tretinoin. Tretinoin is given orally, once or twice daily. Tretinoin 15 days, Q3 months. Every 3 months, we give tretinoin for 15 days. Plus daily dose of tetracycline, plus methotrexate weekly, and this is continued for 3 weeks. Okay, so this is the maintenance regimen in APL. Tretinoin has common adverse effects like nausea, vomiting, it can cause skin toxicity, bone pain, this is common, edema common. These are somewhat manageable. However, we have very important side effect, fatal side effect of tretinoin. We call it retinoic acid syndrome. Now, It's been found that retinoic acid syndrome can also happen with arsenic trioxide and other drugs to treat APL. So now the problem, the name has changed to Apl Differentiation Syndrome or hyperleukocytosis syndrome. There is a sudden increase in the number of mature granulocytes. Okay, leukocytosis can happen, and these can infiltrate to the lung, to the pulmonary tissue, and can cause fatality. فبالتالي classic findings in the Apl differentiation syndrome: deterioration in respiratory function, fever, pleural effusion, weight gain can happen also. At any sign of leukocytosis or at any sign of cough, respiratory symptoms, we have to suspect the differentiation syndrome, and we usually manage to protect patients. And it's not very common, but it's very fatal. So we sometimes take preventive measures to prevent the differentiation syndrome. It can happen with arsenic trioxide as well. What can we do to prevent or decrease incidence of the Apl differentiation syndrome? Any idea?
أضل أعمل follow up وأحسب CBC count.
Yeah, we have to. But to prevent, what can we do to prevent Apl differentiation syndrome? To prevent. By the way, we will talk, when we talk of solid cancers, you have to use the regimens as it is. You should not play with the doses, unless there is adjustment needed. Otherwise, you give the regimen as it is. Don't play with the dose, don't play with the time, the gap, the period between cycles. This can influence efficacy of your protocol. Unless it is indicated that you have to cut the dose or adjust because of renal impairment or hepatic impairment and other considerations. Otherwise, we go with the doses. But generally speaking, when we talk about cancer management, we don't only treat cancer, we have to treat cancer with other problems. Generally, what supportive care cancer patients need? We have to consider treatment for what? Plus carcinoma. We have to treat for what? What complications can happen?
Symptoms associated with cancer.
Okay. Like what?
Neutropenia.
Yes, neutropenia, hematologic support, right? This can happen with what kind of therapy? What is neutropenia?
Neutrophils counts drop.
Yes, a sharp drop in neutrophil count. Why this is dangerous? Because the patient is immunocompromised at high risk of infections, right? Why neutropenia can happen? Why we have to monitor CBC? Differential CBC, what does it mean, differential? Differential means what? When you order differential CBC count, what does it mean, differential?
Every kind of cells.
You cannot give me WBC count in total. I need to know lymphocyte percentage, eosinophils, basophils, neutrophils, differential. Because neutrophil count is very important. Differential CBC. This can happen under what conditions? When we have to be careful of neutropenia. What is myelosuppressive drug therapy? What does it mean, myelosuppressive? So here what we are attacking, bone marrow cells, blasts, other blood cells, right? أنا بحكي مع حالي. ليش متأخر؟ ليش متأخر؟ أنت كمان ربع ساعة اللي دخلت. أنا مش حكيت بتكون on time؟ وإذا تأخر الباص خذ الباص اللي قبل تيجي on time. لو أنا تأخرت عليكم بتقعدوا تستنوني بالمحاضرة 20 minutes؟ تستنوني 20 minutes في المحاضرة، نص ساعة تستنوني في المحاضرة إذا أنا ما إجيت. واللي بيدخل متأخر على القليلة يستأذن، بيقول ممكن أدخل لأنه أنت جايب على 20 minutes من المحاضرة، مش بدخل كأنت داخل على بوفيه. لو أنا ما باجي in 10 minutes you go out وبتعملوا فيستيفال على الفيسبوك، يجينا محاضرة 8:30 والدكتورة ما إجت. وكيف نيجي وما تيجي الدكتورة؟ صح؟ Yeah, this will happen. But you show after 30 minutes, 35 minutes, it's okay. ما في مشكلة. احنا بنيجي عشان نتسجل حضور. والكويز إذا في بآخر المحاضرة we will catch it، مش مشكلة. اللي قاعد على موبايله واللي نايم واللي أبصر وين. كم من واحد بس الأول بس لو هلا قلت شو حكيت you will not know what I said. literally بعد 8:30 ما حدا يدخل. literally. طيب شو يعني كلمة literally؟ روحوا شوفوا الديكشنري شو يعني كلمة literally. ولا دقيقة بعد 8:30 حدا يدخل. المحاضرة 8:30. If you can't make it to your class on time, don't register class at 8:30. ولا 5 دقائق بدي أعطيكم، لأنه 5 دقائق بتصير 20 minutes و 25 minutes و 30 minutes. مثل ما زملائك يكونوا on time, you can make it on time. ولا حدا يدخل بعد عن المحاضرة. هاي أول وحدة، ما حدا يدخل. We give supportive therapy for myelosuppressive drugs, highly immunogenic drugs that can cause nausea and vomiting. We treat and prevent. Drugs can cause anemia, thrombocytopenia. Patient with cancer might have pain. We need to give analgesics and so on. Now, for hematobiotic growth factors, especially in AML, because the therapy is highly myelosuppressive, like RSC, for example, we have 2 drugs approved by FDA. Colony-stimulating factors, filgrastim, sargramostim. The goal is to induce differentiation of amyloid precursor to granulocytes and particularly to neutrophils. So patients with high risk of neutropenia, we can prevent these drugs in advance to prevent neutropenia from happening. Usually we start after we achieve complete remission, because if we start early at therapy, we can induce sometimes more and more of blasts to form. So after we control blast count, we start with filgrastim treatment. And also before we take a bone marrow sample, we also stop filgrastim 7 days ahead to avoid false results on bone marrow sampling. To support patients and prevent neutropenia, we have to maintain hygiene, hand washing. We isolate those patients with high risk of neutropenia, put them in separate rooms. Rooms must be, ideally, they have linear airflow rooms. Air is changed all the time to avoid any contamination in air. Now, sometimes we consider antimicrobial prophylaxis, sometimes. Now, when we talk about antimicrobial prophylaxis, we treat with antibacterials, antivirals, antifungals, or drugs to treat pneumocystis gyri. Now, routine prophylactic antibacterials is not indicated unless the patients are at very high of neutropenia, or they have profound neutropenia. Usually, if neutropenia will happen, it happens within 5, maybe 7 days, up to 8 days after the administration of chemotherapy. Some drugs cause delayed neutropenia, like fludarabine, can happen up to 21 days of chemotherapy. So if the patients are at very high risk of neutropenia, we can give antibacterials, we can give fluoroquinolones, for example. But this is not the routine practice because this can cause antibacterial resistance. Now, in pediatric patients with leukemia, usually routine antibacterials is not indicated for two reasons. First, it does not decrease incidence of neutropenic attacks, and it will increase resistance to antibacterials if we use them extensively in the pediatric patient. However, antifungal therapy is very important, especially if we treat with AML and use SIP-LB. So in pediatrics, routine antibacterials are not indicated, but routine antifungal drugs are indicated, especially for AML therapy. Very important to treat for all patients with ALL is to treat with prophylactic therapy against Pneumocystis jirovecii. What's this microorganism? Classifies as what? Fungus? No. What is Pneumocystis jirovecii? Carini, used to be known as Carini. So this is a very important opportunistic microorganism, and all adult or pediatric ALL patients must be put on prophylactic therapy. Drug of choice is cotrimoxazole, trimethoprim-sulfonitrazole. We start after induction, after we achieve complete remission, and continue for 6 months of therapy. نعطيه 6 شهور starting from induction for all ALL patients, because this is a very opportunistic microorganism. Prophylaxis here is routine. Okay, one important complication that can happen is TLS, tumor lysis syndrome. What does it mean, tumor lysis syndrome? What will happen? Lysis of tumor cells because of excessive cytotoxic therapy. What's the difference between cytotoxic therapy and cytostatic therapy? Cytotoxic therapy kills cells, cytostatic therapy stops them from growing or dividing. So when we give chemotherapy, we kill cells at very high rate. As a result of the destruction of WBCs, the high killing rate, intracellular content will go out, and some patients will have tumor lysis syndrome. How we know the patients developed tumor lysis syndrome? We look at lab findings. So, if there is hyperuricemia, hyperkalemia, hyperphosphatemia, and hypocalcemia, these 4 together, we have to highly suspect tumor lysis syndrome, TLS. Hyperuricemia is the result of extensive purine and pyrimidine metabolism that will lead to the conversion of uric acid, along with hyperkalemia, hyperphosphatemia, and hypocalcemia as electrolyte abnormalities because of excessive turnover. Now, when we treat patients with leukemia or lymphoma, the risk of TLS is high. And for that reason, basically, the goal is to prevent TLS. We have to give preventive measures. If it happened, we have to treat for TLS, because if it happened, it can lead to renal insufficiency, renal disease. Now, if we look at the purine metabolism, pyrimidine metabolism pathway, we have many steps for nucleic acid catabolism. In the human body or in the mammals, the end product is uric acid. Purines end with uric acid through the enzyme xanthine oxidase. So hypoxanthine converted to uric acid is excreted renally. If we inhibit xanthine oxidase with allopurinol, we will decrease formation of uric acid. Uric acid is not that soluble. However, hypoxanthine is less toxic and more soluble. So this is one way to decrease synthesis of uric acid. We can give allopurinol to prevent TLS. Okay? Now, another step, very important, but we don't have the enzyme responsible for in the mammals or the human body, is the conversion of uric acid to allantoin. This step we lack because we don't have the enzyme responsible in the biologic system of humans, the uric oxidase. Now, one drug, a recombinant drug, is basically acting like uric oxidase. The drug is called rasburicase. Now, this step can happen in prokaryotes, in yeast, for example, but not in the human body, not in the mammals. If we give rasburicase, we convert uric acid, the less insoluble drug, into allantoin, the more soluble drug. And so we decrease the concentration of uric acid. So we have 2 options here to manage TLS. In general, to prevent TLS from happening when we start chemotherapy to treat leukemia or lymphoma, we need to do excessive hydration, IV fluids. Patients can take liters, 2, maybe 3 liters of normal saline. before and after chemotherapy to decrease the concentration of uric acid in urine and push the urine to work, to go out. So hydration is very, very important. And to prevent TLS, allopurinol can be very important drug. To treat TLS, in case TLS happened because of chemotherapy, and sometimes TLS happen not only because of chemotherapy, because of leukemia itself, we need to treat. For treatment, we need raspberry case. Okay, so raspberry case is more effective than allopurinol for treatment. Simply, it was a urate oxidase, and so it will convert uric acid into allantoin. In the past, they used to give sodium bicarbonate, but this is now not used. The plan was that we alkalinize urine and so increase excretion of uric acid, but the therapy is very potentially toxic, can cause alkalosis and hypernatremia, so it's not in use. So we either use allopurinol with hydration for prevention or raspberry case for treatment of TLS. Now, hematologic support is sometimes indicated. For example, patients might come with anemia. We said that most leukemia patients present with anemia, with thrombocytopenia, or this can happen as a result of therapy. So when we need to consider platelet transfusions, if the platelet count is below 10,000 cells per cubic millimeter, or a little above, but there are signs of bleeding, we have to consider platelet transfusion. We give back RBCs if hemoglobin is below the cutoff point of 8, or we have signs of distress, shortness of breath, tachyarrhythmia, palpitation, and so on. Now, pharmacogenomics is the effect of genetic makeup on drug response. Now, in treatment of leukemia, we have a very important pharmacogenetic variable, which is about the enzyme TPMT. Trimethyl thiopurine S-methyltransferase. This will add a methyl group to thiopurines, leading to their inactivation. Now, a very important drug therapy here is mercaptopurine or thioguanines. And so, if we have deficiency in the activity of TPMT, the metabolism clearance of thiopurine is reduced and the drug becomes toxic. So for patients with TPMT deficiency, we have to adjust the dose of 6-MP, and usually we decrease the dose 50% reduction, sometimes up to 90% reduction in the dose. Otherwise, it becomes toxic, very toxic therapy. In patients with leukemia, they are determined to be cured of the disease if they are in continuous complete remission for at least 5 years since time of diagnosis. So if the patient stayed in complete remission for 5 years, the patient is determined to be cured. Now, during this time, the patient might be off therapy. If we take example of ALL case, if the patient finished maintenance after 2 or 3 years of therapy, for example, they are still under monitoring, under surveillance. They have to come to the hospital for checkups. Now, the frequency of checkup follow-up might be higher in the beginning, and then starts to decline if the patient is stable. However, they are always under monitoring, and if they stay for 5 years continuously, no breakthrough, if they stay for 5 years under complete remission, then we say that the patient with leukemia is basically cured. Okay, so continuous 5 years of complete remission. What's that? عبوري ما انتهت. الطالب يكتب اسمه ورقمه. This is plus 2. الطلاب الأونلاين أنا أقدر أتهيئ. كل أخذ ورق. سميكم ما أخذ ورق عفوا. السطر الأخير. تعال سبعة. السطر الأخير واليوم. في حدا ما أخذ ورق؟ في حدا ما أخذ ورق؟ Please write the right answer, just the letter of the right answer. فقط حرف الإجابة الصح. That's it. A, B, C, D, or E. يلا جاوب. الورق من ورا لقدام. ما حدا يكتب. ما بدي اسمع صوت القاع. مش مستاهل. بدون كلام. ايش الحكي هون؟ يلا الورق من ورا لقدام. ما بدي اسمع صوت. ما بدي اسمع صوت. مش مستاهل. من ورا لقدام. موف. من ورا لقدام. من ورا لقدام. من ورا لقدام. يلا. عاوز من ورا لقدام. من ورا لقدام. يلا. Do it fast. من ورا لقدام. من ورا لقدام. يلا.
بيعمل ايه حطتها فيه بس Consolidation indication صح شو رح تبلش الدكتور؟
The right answer is B.
بي بدأ شحطتي لين سنها بي
B is the wrong answer. Why? Because it's not induction for AML. It's an induction regimen for APL. B is the statement because it's the wrong statement. شو الاندكشن بالAML؟ شو الاندكشن بالAML؟ انتوا I think تقريبا 3 أسابيع تقريبا. شو الاندكشن بالAML؟ شو الاندكشن بالAML؟ شو اللي ضحك؟ شو ضحك؟ I'm really disappointed at you. ما بعرف شو بدي احكي. انتوا اللي قدكم بدخلوا معكم زملاء تمريض، جينيتكس، applied sciences بتخرجوا اخر هذا القسم. يروحوا على الجامعة. And you still behave like freshmen. Year 1. What you learn, you only come here to learn science, you're away. دكتور لك وجه المحاضرة يحكي حكي ونطلع نروح نحفظ ونيجي نفرغ. And what else? This is what you do for 6 years into pharmacogenomics on. This is your goal. Ultimately, this is what you want out of school. This is the life experience you're looking for when you come register for PharmD program. This is what you want. That's it. الناس تجي على الجامعة بس لحتى تحفظ العلم اللي بالكتب وتحطه بورقة الامتحان. That's it. High expectations في school time. شو الاكسبكتيشنز تبعتكم؟ حدا ممكن يقوم يحكي لي شو يتوقع يعني؟ 6 years starting your school. شو الاكسبكتيشنز تبعتكم؟ What do you expect to learn? What do you expect to have, to gain? شو التغيير؟ دخلت على الجامعة وطلعت منها، شو التغيير؟ بس إنه صار معي ديجري؟ That's it? احنا بنيجي على الجامعة بس عشان ندرس الساينس؟ ولا عشان نتعلم أشياء تانية؟ في شيء اسمه attitude. هذا أهم أحيانا من الساينس. مش كل الناس اللي وصلوا وصاروا كانوا أوائل الدفعة وكانوا معدلاتهم A+ و4 مو هاي هي، مش هذا الأساس. simple common rule instructions بنيجي بنزيد فيها. ليه؟ Why? Why can't you just follow the rules؟ شو صعب كثير إنه أنا أمشي مع الرولز أو إنه أنا ألتزم بالرولز تبعت الإكزام روم أو الكلاس روم. إيش الصعوبة بالموضوع؟ To commit, to show discipline, to show respect to my class. شو الصعب كثير؟ إنه أكون on time. إني ألتزم بالتعليمات. شو الصعب؟ If you don't learn this now, you will never learn it, by the way. حنين للدم. هذه المقداري. ملاك العبد الله. ملك هاني. أحمد عادل. إيمان عبد الوهاب. أماندا فايز. محمد عبد الناصر. مرح محمد. حفصة. دلال عمر. أمان محمد. سليم مجدي. يوسف أحمد. يوسف أحمد موسى. رنيم أحمد. رجين صلاح. آية فاروق. ملاك محمود. وئام خالد. رحمة محمد. عدنان مروان. كاتيا وليد. رؤيا يحيى. مؤمن محمود. ياسر حسن. بتول حازم. تسنيم حمران. شهد عبد الناصر. وإعان خالد محمد شبوط. That's you. شيماء العمات. فرح العزام. لين عمري. سجى خصايا. ولاء البرسان. لبيك أبو سويد. لبيكم. يارا دوابدة. رنا عتمون. طيبة خالد. فرات منيب. آية نواصرة. ربى جلال. ربى جلال الأشقر. سدن عبد النور. أسامة هاني. كلارا موفق. كلارا. إبراهيم أبدية. إسراء علامات. أيسر رياض. أيسر. سناء فوزي. ران جمال. ليلى محمد.